Ladies and gentlemen, good morning. We'll just be starting in a few moments. You've reached the Health Workforce Development through the lens of sustainably led local development webinar. We're so glad you could join us. As you're coming on, we just invite you in the chat just to type in your name, your position, organization, and what country you're in. I'm coming to you from Australia today, and we are expecting a global audience. So welcome, everyone. As you're coming online, welcome. My name's Andrew Brown, and I will be your host today. You've reached the Health Workforce Development through the lens of sustainably led local development webinar. Thank you so much for joining us. We will start in a couple of moments. As we are waiting for other colleagues to join, we would invite you to put your name, your position, your organization, and country in the chat so you can let us know whereabouts you're from. It's going to start in a couple of moments. For those joining, again, welcome. We'd invite you to put your name in the chat, your position, organization, and where you're coming from. And Mackenzie, if you could just go to the previous slide, we'll just go over some of the housekeeping for folks as they come on. We are very grateful that you've joined us in this webinar today. Just as we begin, I'd like to just remind you a couple of things which are so familiar to us on Zoom. Today, we have interpretation. You can click More at the bottom of your screen and choose English, French, or Spanish. This meeting is being recorded, and so we need to remind you of that. We'd like you to double check that your microphone is muted. We also want you to use reactions. So again, if you use your cursor and go to the bottom of the screen, you'll see the react heart icon. If you click on that, there are all sorts of reactions that you can choose, and we would invite you during our webinar to use those. In addition, the chat function for this particular webinar is open, and we would like to invite you to put your comments and questions in the chat as we go on this journey together. Next slide, please. So again, a very warm welcome on behalf of MSH, our panelists, and our WHO representative. We're so grateful that you can be with us for this webinar. This webinar is on the sidelines of the USAID Local Capacity Strengthening Policy Forum. And through this webinar, we are really grateful that you've joined us, and we hope to share with you a few notes and a few important things about workforce in the context of localization. Next slide, please. In this hour, we're going to quickly go on a journey to think about workforce development in the context of local capacity strengthening, tell you a little bit about local capacity strengthening MSH, and then the real highlight of this webinar is twofold. One is an interactive discussion we're going to have with Kenya, Rwanda, and Uganda, with some projects that are focusing on workforce activity there. And then also we're going to round off with some fantastic insights and resources brought to us by WHO Geneva. And then hopefully we will leave this webinar equipped and emboldened to take further action for the workforce. Next slide, please. Firstly, I'd like to get your thoughts. We're going to put up a Mentimeter. And what's one word that describes how you approach health workforce development? In the chat will be an icon that you can use, a link you can click on, or if you've got your phone, you can take a picture of the QR code in order to choose that one word that you would use to describe how you approach health workforce development. And as you're doing that, if you're coming online, again, welcome. We'd invite you to put your name, your position, your organization and country in the chat for us. What's that one word with that Mentimeter? Okay, we had a couple of different words coming in. Invest, skilled, collaborative, informed. Let's see what else you can put in there. So you can use your phone in order to use the QR code. And Melissa, I think you're dropping the link in the chat for this one. So I don't think that's come in the chat just yet. So thank you so much, Melissa. Great, some great words coming in there. Um, and if you can't access the Mentimeter for any reason, then if you could just put that in the chat. Great, some Aussie words there. Thank you for sharing that. Next slide, please. As we think about workforce, one of the things through my career in workforce development, and I noted my name is Andrew Brown before, but I forgot to mention to you that I am the workforce development lead in MSH and work across our projects. And one of my, if I could give you all a badge for coming today, I'd give you a little badge to say that capacity development or workforce development, HRH approaches, is not just training. We need to take a holistic approach. So what does that mean? From my perspective, if we're going to achieve UHC, countries need adequate numbers of competent health workers who are motivated, supported, and protected. So not just competent, motivated, supported, and protected by their organizations. And those organizations need to use data to plan, manage, and optimize the workforce to address current and future challenges. And I think together we are working for this outcome in country context. This is, of course, much more than training. And most of all, we need to ensure that we support local actors to be able to lead these efforts. Next slide, please. I'd like to share with you what we're doing at MSH in this regard. A number of people on this call will be aware that Management Sciences for Health is 50 years old. I think it was last year or the year before. And our founder was inspired by the principles of locally led development before they were called that. And on the screen, you will see a poem that's the Tao of Leadership that you can read through. And this really, this poem, this Tao of Leadership by Lao Tzu, really underlines everything we do in MSH. And as an organization with a mandate for health system strengthening, we always have worked shoulder to shoulder with our colleagues and partners so that at the end, it appears that they have done the work themselves. And that's how we like it. What's interesting over the last few years, and particularly the last year, there's growing evidence and consensus on the critical role locally led development plays in sustainable development. And MSH, you'll see at the bottom of our tree there, has localized as the foundation, the roots of what we're trying to do in MSH. And this tree represents our strategy. Next slide, please. Within Management Sciences for Health, we have a local capacity strengthening practice area. And these are the four aspects that we're aiming to achieve with this renewed focus. We want to foster this locally led development in programming, amplify local voices. We want to invest in monitoring and evaluation around this to see that we're making a difference. And we want to prioritize strategic local partnerships. Concept of workforce, it's much more than training. We've got this concept of localization and our focus on that through Management Sciences for Health. Next slide, please. And it's our pleasure today to have a discussion with three of our subject matter experts in three different countries of the world around this particular aspect. I'd like to introduce to you Nadina Kusu, Country Program Director from USAID MTaPS program in Kenya. Welcome, Kusu. I'd like to introduce to you Martin Oteba, the Deputy Project Director for USAID Supply Chain Strengthening Systems Activity from Uganda. And Joseph Shima, also welcome to you, the Principal Technical Advisor for the USAID-IREME activity in Rwanda. When we chat with Kusu, we're going to be looking at how we ensure ongoing use of e-learning. From Uganda, we're going to be looking at integrating supportive supervision. And from a Rwanda perspective, we're going to have a look at locally driven scholarships. This particular slide will stay up during our panel discussions, and you may note there's some QR codes there. If you'd like to learn a bit more about our subject matter experts, which we encourage you to do, we would ask you to use the QR codes there to go to their LinkedIn profile. And for each of the projects, you will see that there is a code that will take you to give you a deeper understanding of the project. With our chat today, you'll see different links go in the chat, which you will note as resources, either highlighting our panelists, their activities, or resources from those projects. In doing things in this multifaceted way, we're trying to give you access to a range of resources and further information. Okay, so let's hear a bit from our panelists. Joseph, Martin, and Kusu, I invite you to unmute yourself. And first of all, just say hi. Joseph, how are you going?
Hi, good
Great,
morning,
thanks, Martin.
everyone.
Hi, I'm fine. I'm fine. Thank you, Brown.
Thank you, and welcome, Kusu. You're just muted there. I'll invite you just to unmute the microphone, Kusu.
Oh, thank you. Hi, Andrew. And hi,
Yeah,
everyone.
exciting to have you here. Now, one of the interesting aspects of this panel today is that we're doing it from the perspective of implementing partners in country. In future panels, we're going to make sure we highlight that locally led country perspective from the local organization's perspective. But today we want to think about the implementing perspective. So, Joseph, let me ask you first, what was the workforce development issue you focused on? Why did you choose it? And what local organization are you working?
Thank you very much, Andrew. The workforce challenges that we're facing here in countries, it's a shortage of healthcare profession, as in other countries as well. But there is inadequate education and training, retention of healthcare workers remain a big challenge worldwide, but particularly in Rwanda, and maldistribution even on the train and available health workforce here in the country.
Mhm.
Thank you.
Thank you. And I just invite you just to come a little bit closer to your microphone. You were just fading off a little bit there. So that'd be great. So Martin, in Uganda, you're doing something completely different. So what is the particular workforce issue that you've been seeking to address in your supply chain project? Why was it chosen? And what local organization are you working with?
Thank you, Andrew. The workforce issue we have been grappling with in Uganda relates basically to the challenges related to the management of health commodities in the country. And as you spoke earlier, the challenge of numbers and skills related to supply chain management. And so we work with a myriad of stakeholders here, partners, including the local governments at the national and subnational level, to address this matter in a more holistic, collaborative manner. Back to you.
And I understand that today we're going to be that supportive supervision was a key element that was under addressed in your context. And we're going to be looking at that. And Joseph, what you mentioned to in your context there is that this aspect of locally driven scholarships, which I think is really important, and you're going to bring that out. Kusu, something completely different from your MTaPS project. What's the particular workforce issue that you've been focusing on, and why did you choose it? And who are you working with to solve it?
Yeah, thank you, Andrew. For Kenya, the MTaPS program has been supporting global health security work around containment of AMR. And so we had to strive right from the beginning in 2019 to, one, increase the skills, the capacities around containment of AMR, and then also, promote infection prevention and control. And this was also further enhanced, with the COVID-19 pandemic. So in terms of the local organizations, we employed a whole market approach, of course, the government, but for the particular area that I want to highlight here is really working with the private sector, the health professional associations, as a conduit to many practitioners within the private sector, the community retail, pharmacists, the faith-based sector and the public sector. But then also making sure that we link this to the continuing professional development.
Oh, there's some exciting questions I want to ask you about how you were able to do that. But I think the exciting thing here is that AMR or antimicrobial resistance is sort of countrywide. So the approaches you've taken from a workforce perspective is to engage with those professional associations and other groups that really engage the whole market of workforce, not just focusing on government entities. And I think that's a key difference to your particular project. Joseph, I want to come back to you at this stage. We can say things like local capacity strengthening very quickly and very easily. But I'd like you to take a moment, please, just to tell us a little bit about how you have applied a local capacity strengthening approach and what were the actions you've agreed to take with your local partner.
Thank you very much, Andrew. As the country, we're facing a very big challenge in terms of health workforce. So USAID-IREME, the project we're implementing as MSH in Rwanda, focus on supporting the Ministry of Health and all other stakeholders into the production. And the top first priority goes with the midwives in countries. So with the Ministry of Health, Health Workforce Development Department, we went through different local teaching institutions to strengthen their capacity and provide scholarship for 500 midwives in country. So, and on top of that, as we are conducting as well the workforce indicators for staffing needs, our aim is as well to strengthen the healthcare facilities into workload indicators for staffing needs for them to incapacitate them and produce data to allocate efficiently resources in country. On top of training as well, the students and develop their career pathway, make them informed, mentor them so that they enter into a career with a long run objective to stay. At the same time, we're solving a challenge that we encounter of retention and motivation of healthcare providers in country. Thank you.
Thank you so much, Joseph. I'm going to give you a reaction of a great big heart. That made my heart sing. And the reason it made my heart sing is often in projects, we're thinking about how can we train those people? How can we get them out into the workplace? But we don't think about the demand and how to allocate them. And although I can't see Catherine Kane on screen from WHO, we'll hear from her because the supply and demand, there you are, she's singing. I can see that singing, that you spoke about a considered effort. And as you told me when we spoke offline on a previous occasion, these particular priorities came from the government. You didn't go in there and say, this is what we want. The government came to you and said, here is our strategy, here are the points. So thank you for sharing those aspects. So Martin, everyone does supportive supervision, but you guys are doing it a little bit differently. Can you please talk to us about how you have applied a local capacity strengthening approach around the issue, and how did you agree with your local partner organizations to engage in this area? Thanks, Martin.
Thank you again, Andrew. As I mentioned earlier, the challenge of numbers, the challenge of skills, our approach was based in the first place on the fact that the district local governments who actually supervises the health facilities at that level demonstrated interest. So what we did was we actually called out for an expression of interest at some point, and all the district local governments did express their own interest in what we are going to do. And here, realizing that they all had the interest, we worked together at national and subnational level using some representatives, developed a tool together that would then identify specific district-focused supply chain management challenges. And based on this, we then worked together to develop even the materials for capacity building. We identified, of course, there's a mainstream training as one of them. But as you said earlier, there are other issues like tools to use, basic things that will be required to improve the performance of a provider. And note, because skills were low and we couldn't get the specialized trained people, we had to use actually the WHO philosophy of multitasking. so the district health office picks the people, selected the people of their choice, whom they thought would be trainable and able to deliver supply chain functions. They could be laboratory, nursing, you name it. And then we worked with the local training institution, the university, the Faculty of Pharmacy here, ran through the materials. We, as MSH, we actually developed their capacity as trainers of using this material that we had. The district's workforce coming to this point, to the university, to be trained in certain quanta and followed through with the specific supervisory interventions, doing constant self-checks through an elaborate assessment tool together with these workers at base, identifying the gaps, whether they are policy gaps or practice gaps or infrastructure gaps, and collaboratively with many other partners, UNFPA, Global Fund, and others, we supported the districts either through procurement of storage infrastructure like shelves, gave them some dispensing tools, continued to give them the logistics for moving around in the district to supervise the facility and mentor staff at the health facility level. We called this cadre that we developed medicines management supervisors. They became the go-to persons in the districts, and they supported a region within the district to ensure that the health workers who are really at site are provided the necessary hands-on training and capacity built for them to continue this without these medicines management supervisors. And that is up to now a process that's ongoing. We have moved a stage ahead by having realized the benefits of going this way. We also realized the costs that go with it, because we had to fuel motorbikes. We had to maintain these motorbikes. We had to buy them computers and make sure that they had the bandwidth for them to be able to collect data and submit the data on commodities to the national level. Ultimately, we have now gone, in this current project, we've gone to the level of using technology to remote approaches, e-learning, self-assessment, then e-learning, where a facility, an individual goes in, does a self-assessment as an initial entry, and is evaluated, and then based on the results of this pre-assessment, the individual is led into a package of online training based on the areas of weakness. And after that,
let me come in at that point. I think what's really exciting about what you've said is that you started off, I think you said together about 4 or 5 times about how the district entities came together. You looked at the issue together, you developed the materials together, you chose the people together. But more than that, they chose the people. And then you've gone on to describe a number of other elements that come together to make that a whole system of supervision. We're going to come back to you, Martin, and ask you a couple of another important question. But in the interest of time, I'd like to move to Kusu, because Kusu, your particular story is quite interesting. So I'd like you, building off your earlier question, how did you apply this local capacity approach? And what were some of the actions that you agreed to take, focusing on this local concept?
Yeah, thank you, Andrew. I think as we started the MTaPS in Kenya, we knew we had a hard task ahead to create awareness, to build capacity, and change, improve on knowledge and skills for containment of antimicrobial resistance. And allow me to use AMR for my conversation in short. And when we looked at what the external scores from WHO, the joint external evaluation scores were, for one, the multi-sectoral coordination and microbial stewardship and IPC, they were low. For infection prevention control, which is IPC, was at 3 at that time, and and microbial stewardship was at 2. And then we also knew we needed to employ that a multi-pronged approach so that we could create a mass of converted AMR champions. So right from the onset, Andrew, during the scoping, we engaged the local organizations, the local partners. And we knew for pre-service we would work with the university. We also knew we needed to also do in-service working with, the counties and the ministries of health and other, other counterparts. But to ensure that we got more numbers on board and reaching people who are within the different sectors, we had to reach out to the professional associations. As our examples include the Pharmaceutical Society of Kenya, the National Nurses Association of Kenya. And so during the scoping, we spoke with them and tried to understand what the gaps were and how we needed to move forward so that we could, have a course that can be implemented for continuing professional development, CPD, with the CPD points, and also that is going to contribute to their relicensure through the regulatory bodies. So what then we did was, we said we need to be structured, we need to understand what the needs are. So we undertook training needs assessment jointly with the associations to tailor make the training package on infection prevention control and the other training package on AMR and on microbial stewardship, working with the Pharmaceutical Society of Kenya, plus the other health professionals, the PSK for the pharmacy professionals led the development of the AMR AMS course, whereas the National Nurses Association of Kenya led the development of the IPC package in collaboration with the other health professionals. So after developing the packages, we actually pilot tested them, and I'd say they were informed by training needs assessment. And then subsequently, we actually jointly implemented them, again led by the health professional associations. And for us, then we again discussed and said, what would be the best mode of delivery of these training packages? This was during COVID and post-COVID. And we also know that we are private practitioners that work during the day. They don't necessarily have a lot of time during the day to sit in classroom for 3 days. So we said, we agreed to roll out the trainings in the evenings, led by the associations. And we broke down the modules to stagger them to be delivered during different sessions. And each of those sessions would accrue continuing professional development points for the different health professionals. These points were again granted by the regulatory councils. And, they were incentives, because as a health professional, I need to get CPD points for me to have my license renewed at the end of the year. And this was quite effective because we started with the IPC and the AMR. But I tell you, we also scaled up that model through the same associations for COVID, for pharmacovigilance, and even other newer emerging areas. So specifically for AMR and infection prevention control, through that collaboration with the different associations, including the Kenya Medical Association, because these other associations also took the same packages, we were able to actually train a huge mass within a short period, reaching over 10,000 health professionals from the different sectors.
Big numbers.
Yes, big numbers and very engaging. Sometimes we would have a session that has even almost, 500 plus participants. I'll even surprise you by saying sometimes we even had people joining the sessions from outside the country, again, to ensure that they are licensed within the country. Thank you.
Great.
And back to you.
Thank you so much. And I think what I like there is, again, how many times you said together. And I can see your passion and excitement about engaging the whole marketplace around these things. So that's great. So while you have the microphone, Kusu, I'd like you to tell us what's one lesson, one crisp lesson that you learnt that you can be confident that when you leave the project, what you've done sticks. The work you've done will continue. What's one lesson you've learnt?
Thank you. There are many, but I'll just stick to one. That early engagement, jointly planning, developing the package together, and rolling it out, and building the capacity of the key champions within those associations to sustain the capacity building interventions. And then also going further and lobbying with them within one lesson for them to prioritize antimicrobial resistance, infection prevention, control, and microbial stewardship, and ensure that when they come up with calendar of events, the webinars, then they have enlisted those so that they get a slot, and so that trainings go on even with MTaPS being out of the scene. Thank you.
Thank you. Thank you so much, and very clever to put in those sub points from your number one point. But that engagement, I think, is clear, coming out very strong and early. Martin, from your experience, what's that one crisp lesson that you've learned over the last few years so that you can ensure that what you've done will stick, that this supportive supervision program will continue after you've gone?
It is always easy to mention the word ownership. But ownership, by the time you hit that level, real multi-stakeholder engagement and provision of tools that will be needed for your intervention to proceed. As I concluded the previous question, Andrew, I did mention that we developed now digital tools, and those digital tools are now held. They have been transitioned to the Ministry of Health websites with access by all the district health offices and even some of the district political leaders. They can access that for various purposes, including looking at how their district or a facility in the district is performing, and therefore hit on the leadership of the technical teams. Why are we performing badly, and so on. And subsequent to that, the fellows have the urge, the drive to be able to hit on the website, do the assessment, find out where they are, and proceed. The entire business of ownership of what we've been doing, having done it multi-sectoral, multi-stakeholder, really helped, I think, fixes this. And to tell you the truth, when we started, we started in the previous project, but as we talk now, partners, high-level partners, international partners, you are using the SPAS, the Supervision, Performance Assessment, and Recognition strategy that we used to enter to support the districts and facilities of their choice. That's a wonderful thing. Ownership. Thank you.
Ownership and integrating into systems. And I noticed a question in the chat from Bill Burdick, and really you spoke to that by making sure that the system is institutionalized and integrated into what you're doing. Joseph, I want to come to you. Your project is a lot newer than the other projects. You've just started a year or so. What's one lesson that you've learned so far that you're putting into practice to make certain that the investments that your project's making will continue after the project finishes? And for those in our participants, please, if you have questions, please type them in the chat. Thank you so much. Joseph, do we have you? Yes, you froze for a moment. Yeah, what's one key message you'd like to share?
So, thank you so much, Andrew. As we say, nothing for us without us. So USAID-IREME has prioritized, first of all, to align with the national strategy, align with the priorities set by the Ministry of Health. But with that, we started with, first of all, revitalize the technical working group that where all stakeholders are met with all the partners as a health system strengthening project to revitalize that technical working group so that we work together, we implement together, we support together, the national plan and priorities. On top of that, we work closely with the Ministry of Health and all the stakeholders, means the professional regulatory bodies, teaching institutions, health facilities, so that whatever we implement that is in the policies and strategic document remains. What we do is to support them implement it in a sustainable way, creating and work on the tools that can ease the implementation and make sure that everyone is informed and has the same information. And we do the assessment and monitoring to make sure that whatever that we developed, whatever that we supported, remain, not only for the Ministry of Health, but for all stakeholders around the priorities. Thank you.
Thank you so much, Joseph. I think each of you, again, we could speak for a long time about how you are seeking to be sustainable, but I like your comment about not with you, without you. I think it's important. Martin, about integrating into existing systems, and Kusu about that stakeholder engagement and bringing people together. Please, ladies and gentlemen, join with me in choosing a reaction to show your love or excitement for what you've heard today. And again, these are tasters. In the chat and on the screen, you have got access to more detailed information. Joseph, Martin, and Kusu, it's been a pleasure. We're asking our participants online to put questions in the chat, and we'd invite you to be responding to those in the chat as we move along to the rest of our webinar today. You're getting lots of reactions going, really excited. Thank you so much. Next slide. Thank you, Mackenzie. So that was an exciting but brief journey into 3 of our questions and what's happening. Next slide, please. And we'd invite you to put some questions in the chat. But what's exciting is that globally we have WHO as the standard setter, as an organization that can provide to us tools and approaches that are grown from local experience, but available locally. And with that, I would like to invite Catherine Kane, who's a technical officer of WHO, to come and give us a 15-minute overview of some of the key tools and approaches that can be thought about and applied in country local contexts. Catherine, the floor is yours.
Hi, everyone. Next slide, please. I'll point out that what I'm doing is an extraction of what a colleague just did as an introductory course in a day. So I'm going to go very quickly, too quickly for some, not quickly enough for others, but I understand that we'll be able to disseminate these after. So starting out with, how do we make the sausage, as I heard in my early days in health? How does WHO create guidance tools, et cetera? And it is, as many of the panelists have already indicated, a team sport. So the need is identified. We talk to our country and regional offices. The World Health Assembly might make a request that we develop a tool or a piece of guidance. We observe a trend or an issue within the context of our work, and that prompts us to start the process. Then we do a call for experts. We ask internal people in our departments, regions, country offices, our UN partner organizations. We ask external stakeholders. We put up notifications of interest that we disseminate through all of our social channels. We ask partners to put them out, and we say, who's an expert in this area? Who's got something to bring? And then we look through everybody who expresses interest, and we actually go through dialogues and processes to say, well, I can see this person is from academia, this person is a health worker, who are very important elements in our discussions about what do we do with us? Nothing without us. Nothing for us without us. And then we go through and we look for regional representation, gender representation, representation of other diversity issues. And then we bring this into a technical advisory group. Then we go through evidence and drafting. They review all of the evidence out there. We do successive drafts of the guidance. We put this out to all of the technical stakeholders, sometimes hold a town hall-like discussion in order to get more perspectives if we feel like the evidence or the research is lacking in a certain area. And then we agree through many, many meetings with our technical advisory group on the final text. And then that goes through a really exciting, and I know most of you have probably done this in some form during your lifetime, publication process, which of course is rapid and seamless and see-through. But eventually we get to do our favorite part, which is dissemination and outreach. We announce it to the public. We do conferences, webinars, events, seminars. We talk to groups like this. We talk to special interest groups. We do workshops in regions and countries, and then we try to figure out whether we're doing it right and whether people are taking up these tools. And finally, we report on that. So usually with a tool, for example, one tool that I'm involved with is the Community Health Worker Guideline, and we'll be reporting back to member states in the World Health Assembly in May how we're doing in terms of taking up the recommendations in this guideline that was launched in 2018. I've done one report. This is my second report. We may be coming to some of you. Next slide. So let's talk about why we're doing this. And if we just go to the subsequent slide, why are we doing this? Because health workforce, first of all, we've got a projected gap of 10 million health workers globally to meet projected needs by 2030. The distribution isn't proportional to population health needs. High-income countries have 23% of the stock of doctors, nurses, and midwives. Incidentally, nurses are 59% of the global health workforce. So this is a pretty big deal. And Africa, which has growing health needs and growing population density, has 4%. Next slide. So what's our structure? How do we start with? Go back one, please, because this is a really important one. This is our global strategy on human resources for health. This guides our work. It was put out and approved by the World Health Assembly in 2016, and this guides all of our work, including, you'll see on the right side, our Working for Health Action Plan, which is one of the principal ways that we work in countries to optimize, build, and strengthen the health and care workforce through planning and finance, through education and employment, and through protection and performance. So a lot of these were actually touched upon with our panelists, and now we'll go to the next one. And so what do we look at? When we talk with countries, we try to figure out what we need to do to develop the health workforce for universal health coverage. And it's a series of enabling functions that are interlinked that in turn require other elements. So this is, we used a revision of these concepts in order to rapidly build our COVID-19 guidance, which I was privileged to be one of the principal authors on. But it looks at tools, individual factors, organizational environment, system-wide factors, and then what we call a conducive environment. So socioeconomic development, I think all of us here can probably identify well with where we are now. Political will, which is very different than the socioeconomic environment. Health and education are really excellent sectors for investment, as I may have heard a CEO say in the past 2 days. So what next? Cultural factors. So does this fit with context? So all WHO guidance, I should emphasize, all WHO guidance is written for all in any country to be contextualized to the local needs. And then the next is favorable geography. Can we do this? Next slide. We're looking at a paradigm shift. Traditionally, and you look at this in the past, health is looked at as a cost and disease and a drag on the economy, and growth in the health sector without increase could constrain economic growth. We have this confirmation of the hypothesis. We have changed dramatically. Now we are looking at, and this is accurate, we have countries who in fact demonstrate this. Health is a multiplier for inclusive economic growth. We're working with the World Bank. We are working with other partners to demonstrate where you invest in health, and particularly in health workers, you are investing in the local economy, you are investing in creating education channels, you're investing in jobs, you are investing also in improving population health. But the workers are in fact a lens for this. So let's go to the lens for this. Oh, I'm so sorry. It looks like somebody's got their microphone on along with me, and you can hear me twice, which probably isn't necessary. Next slide. Health workforce, a gigantic expense item in the SDG gap. We have 6 years left and we are behind. And external investments aren't reaching the health workforce. So what are we doing about this? Next slide. Among others, let me just introduce our most recent, one of our most recent exciting announcements, which is, in fact, the Africa Health Workforce Investment Charter, which looks at the several key principles, including government leadership. Prioritization is informed by evidence, alignment and synergies across the health workforce investments. So looking at where you invest, for example, if you're investing in training or education, is that cascadable so that you're investing in training of the trainers, which in turn invests in the competency-based education of the workers and creates opportunities for workers to grow into trainers themselves, into stimulating investments and looking at how we gather partners. And instead of each civil society or each bilateral partner investing in the program that's going to do what they need to do. I'm going to invest in malaria and I'm going to make malaria grow. And I'm going to do this through one single occupational group. What we're saying is, and in fact, this came up already in our conversation, what we're saying is talk to the government, find out what the government's priorities are, look at the human resources for health strategy, look at the communicable disease, the non-communicable disease strategy, the health promotion strategy, the community health strategy, and align there. And put your investments towards those government strategies because governments know how to spend money and they know what their priorities are. So you've got to put yourself in the backseat and let government drive. It's really hard, but it's also necessary if we're going to develop context-specific interventions. So next slide. Countries aren't on the same path. So one of our big problems is that we don't have currently the education capacity in all countries to cover the needs over time. So this just gives an idea of some of the regional distribution of learning, education capacity, educational development. For us, the health workforce actually starts right in the beginning, and it starts with assessing the health needs. Then you look at how many health workers do we need to meet the population health needs. Next, you look at how do we need to educate the workers with the competencies needed to meet these needs. Then we look at employment. How do we employ the workers? How do we ensure that there are enough jobs for the workers so that we're not creating 3,000 doctors and we have fiscal space for 30 doctors? So it's about evening out that labor market and ensuring that education meets competencies, meets production, meets the labor market, meets the overall needs. So going to the next slide, what am I talking about with competency-based education? Because this is really important, and this feeds into a lot of the tools that we're doing now, and it's preparing health workers in a way that's oriented towards the health outcomes, and that is by analysis. It de-emphasizes going to training. It's a 24-hour training that I go for over the course of 3 days, and then I answer a multiple choice questionnaire, and then I'm good. What this really looks at is ensuring that the learner is equipped not only with the knowledge, the pieces of information, but also the skills through mentoring and with the competencies, the know-how, and then shows how through practice activities. So this is a very interesting area that we're working on right now, particularly through the Global Competency and Outcomes Framework for Universal Health Coverage. Next, what are we doing specifically with countries, for example, in the public health space? All of us have come through the recent COVID-19 pandemic with a blunt awareness that our health workforce isn't substantive, isn't big enough to meet the needs that are coming out. Whether that's needs for health emergency preparedness and response, or whether it's needs for public health, promoting health, ensuring that populations are more resilient, to use a popular term, and don't feel the impacts as much. What do we need to do for those? We also recognize that it's not just health workers, it's public safety workers, it's water and sanitation. There are any number of workers. So we're taking a 3-step process with countries to identify what the essential public health functions are adapted to the national context. If you don't have malaria, don't develop malaria. But if you do have malaria, make sure that you have all of the epidemiologists, all of the community health workers doing ICCM in communities. Look to build the workforce for that and the competencies for it. Second point, when you then have identified what your essential public health functions are, you take step 2 and you identify You map and measure the occupations that are doing it now and the ones that you need in order to do it. And that allows you to grow that workforce very specifically and deliberately through action 3, competency-based education, working with, and we've talked about health workforce being a team sport, working with academic institutions. They buy in, they own, they adjust curriculum based on population health needs. And we have a set of tools ready to help countries to do this. Next slide. We also have good practice statements and recommendations. So as I talked about our process for developing guidelines, there's not always enough evidence to say what works. What we do is we lean on experts, we lean on country examples to make good practice statements and recommendations in order to lead in a direction that may eventually look at us revising guidance, but at least identifies the questions that you ask in order to get to important areas. And I haven't heard equity yet, but that's huge. There's no health unless we're reaching everyone. The World Health Organization has a focus on health for all, and that is healthier lives, better prevention against disease, and better resilience against emergencies. So promoting health is one of them. So how do we get there? We ensure that everybody has health, and that is most challenging often in rural environments, hard to reach areas. So we actually have a guideline on that. Here you go. Next slide. And I am racing through these. So all of this is really interesting, but we're talking about how to structure your human resources programs in order to achieve outcomes, in order to achieve population health. But in order to do that, what you need is a health workforce that is protected and supported and invested in, and we are investing in people. It's not people-centered health services, it's people-centered health systems, and that includes the people who work for the system. So this is another really strong outcome that wasn't something that we actually learned during the pandemic. It just got a really straight reminder. And the Global Health and Care Workers Compact that I hope all of you will consider taking up looks at the rights at work, employment opportunities, social protection, social dialogue through the lens of 4 domains. And these are really tiny, but I've got so much more information about this. This is one of my passion projects, preventing harm from occupational hazards, violence, and harassment during situations of fragility, conflict, and violence from health and mental health impacts that are occupational by providing health and mental resources to employees, to workers, through inclusivity, equal opportunity, and non-discrimination. If anyone here has the statistic, please go ahead and put it in the chat, and I'll give you the right one. What is the percentage of women in the global health workforce? And then bonus points, what's the percentage of women in leadership? And triple bonus points, guess how much women make in comparison to their male peers who are equally qualified. So I'm a woman, Andrew's a man, we're probably about the same age. Sorry, don't mean to insult you, sir. But adjusted for location, are we making the same money? Anybody think so? So ensuring inclusivity, providing supports, so that's fair and equitable compensation, social protection, that's your family leave that includes men and women and parents, all parents, enabling work environments, supportive supervision. Did anybody hear that one? Safeguarding rights. So you have the right to freedom of association. I heard here a discussion of professional associations. You have that right. That's important. You have the very important right and obligation for whistleblower protections. If you see something going wrong, you've got to raise your hand. It is your ethical duty as a health worker to do so. Next.
Catherine, we have about 2 minutes, just to let you know.
I know. Okay, and I'm going to go quickly. So, big issue, migration. There is something governing migration from state to state. Countries have agreed to this, and there's a code governing it, which is the WHO Global Code of Practice on the International Recruitment of Health Personnel. This is going to be reported on at the World Health Assembly in May. There are a number of guidelines, a number of negotiations, and an expert advisory group that's been convened for about 10 years looking at this very important issue. Governments and employers have obligations. Next, the support and safeguards lists. There are 55 countries. This is an increase on the 47 that were there prior to the pandemic, where they have an outsized burden of population health needs and an undersized health workforce, and these are prioritized for safeguards and support. Next, and I'm just going rapidly. Bilateral agreements govern these. We just came out with some new guidance within the past year. Encourage you to take a look at that. Next, how do we deal with all of this? We do data, dialogue, decision-making, and as you guys might guess, dollars. So data. We have identified in every country since 2016, and this is really exciting, the national health workforce accounts. And we have progressively gotten more and more data that is validated against the same standards for every country through a validated process, which puts out the Global Health Observatory data on health workforce, and that comes out annually, but it is data from the previous 2 years because it needs to be processed, analyzed, et cetera, in order to inform good decision-making. Next. Health workforce data and availability and use. When you look at data, when you concentrate on, when you agree on processes through, again, the World Health Assembly, where countries said, yes, we will share. Look at where we've gotten from 26% in 2013 to 81% reporting in 2022. Isn't that amazing? We can do it together. Next, how do you do this? Well, here's your kind of cheat sheet on how you approach human resources for health. You can actually look in the National Health Workforce Accounts handbook and get a guide for all of the elements that you might be looking for in country. And you can find every one of your own equities within this, as well as I did it, in our last slide, resources and tools. So there are lots of really, really lovely resources and tools. And on the very bottom, we have the WHO Health Workforce page, and you will find all of the resources on that of everything, hopefully, that we've published. If you're looking for something and don't find it, feel free to flag it to me. In addition to being one of our very avid spokespersons, I also manage our website, which is fun. So all of us multitask, team sport, multi-stakeholder. Looking forward to speaking with you.
Thanks, Catherine. And on behalf of our group, just to apologize to the translators, but thank the translators for their help. What was exciting, Catherine, is really the roll call of resources. And particularly what was exciting is the consultative process the WHO goes through to generate evidence and generate tools. Next slide, please. I think that's really exciting and sometimes we overlook that. Please put your questions in the chat because we're going to answer those offline for you and let you know. So do that. Next slide, please. So we'd like you just to quickly take the time, just one word to describe how prepared you are to undertake health workforce development in your context. There's a Mentimeter link in the chat, and then also you can use the QR code, which can take 30 seconds. What's one word that describes how prepared you are to undertake health workforce development in your context? Just as we're going to that, we'll go to the next slide. So we've taken you today on an express journey. 60 minutes goes very fast, but there are 4 key messages that we want you to take away as we think about the USAID Forum on Local Capacity Strengthening. We've been thinking today about the workforce interventions and workforce context. So the first point is that sustainable health workforce development is much more than training. There's a systematic approach, and we're so grateful to Catherine to really point out all the tools that help us understand and apply methods to help us in that regard. But having local organizations prioritize and lead interventions is critical for success. And what we've tried to do today is to give you a couple of case studies from our experience. And I'm sure many on the call have experiences that they're able to share as well. We want you to consider WHO health workforce tools for application in your context. There are lots of tools and resources available. They can be applied in your context and can really help you accelerate your progress to improved workforce availability, productivity, and the satisfaction of that workforce. We recognize that today couldn't have happened without the help of our team. So particular shout out to Mackenzie and to Melissa for involving all the behind the scenes work. I want to especially thank the participants who I'd invite, please, to give one more big reaction. And as you go back and whatever else you're doing, I want you to think about what's one point of action that you can take as you engage with others around you, as you engage local actors in order to improve workforce investments, to improve the availability, the support, and the use of workforce. Details of our speakers are on the screen, and we'd invite you to follow them up if you have more questions. And with that, I would like to, on behalf of MSH and our speakers, thank you very much for attending our webinar today, and we wish you well. And I'd invite you to come off screen and wave goodbye to your colleagues. And Mackenzie, if you could stop the slides and just go to a gallery view, we can just say goodbye to our colleagues. So you're welcome, folks, to put your camera on if you have that capability and wave goodbye. We thank you very much, and we wish you well for the rest of your day. Great to have so many colleagues from around the world join us, and we look forward to working with you. If you have questions and want us to follow you up, then our details are in the chat, and we would love to have your emails. So thank you very much, and we invite you to enjoy the rest of your day. Catherine, a very special thank you for you and WHO for allowing you to be available to speak to us. Lots of great resources there, and we'll be following up with others. Bill and Laurie, thank you for your comments, and Lizette, others. Appreciate your comments in the chat. And again, a thank you to Melissa and also to our interpreters who need extra special love. I'll give you extra special love to the interpreters for such a fantastic job. And we look forward to our next event together. With that, we're going to sign off, and again, wish you well for the rest of your day. Thank you very much. Bye for now. Thank you.